We're going to kick it off today by Ramez Iskander. Welcome, my friend, and take it away.
Thank you. I'm super excited to be here. It's always thrilling to have conversations like this. For the sake of time, we're going to review a lot of content that is familiar to many of you in the audience, but like was mentioned, we look to contextualize it. And I'm joined here by my good friend and colleague, Brian Slomovitz, as well. So we know endometrial cancer reflects an unmet medical need. And not just because it's a disease that's of rising incidence and mortality, both regionally and internationally or globally, but because it's anticipated to surpass ovarian cancer as a leading cause of gynecologic cancer mortality in the coming years. So there's a lot that has to be done. And there's also racial and ethnic disparities in outcome, which are clearly important for us to address on an area of shared priority, which hopefully will allow us to make inroads in the future. I love this slide. It was adapted from one of our sarcoma doctors. It says, we've gone from the light microscope to the molecular microscope. This ties into the presidential presentation that we had this morning in the lung cancer arena. But thankfully, I think we are proud to say that we're seeing similar progress in the GYN cancer space in a very meaningful manner. So we know that single-agent immunotherapy in a biomarker-negative population has been ineffective. And that was shown in the Garnett trial, in the Keynote 28 trial, as well as the Phaedra trial, and looking at avelumab. Response rates of 5 to about 12%. Clearly, much more needs to be done. So we've explored options for combinatorial strategies in many different disease settings, not just endometrial cancer. And we've seen, for example, in lung cancer, that combination of chemotherapy with immune checkpoint can take a malignancy that's historically thought to be not immune responsive and augment response to immunotherapeutics. And why is that the case? It's based on a few different premises. One is that cytotoxic chemotherapy itself can be immunogenic by leading to immunogenic cell death. It can reduce myeloid-derived suppressor cells and regulatory T cells, and essentially help bolster the response to checkpoint in a disease where checkpoint alone in a biomarker-negative patient was not effective. But in the same breath, the hope was to take very provocative results with immunotherapy in mismatch repair deficient biomarker-positive patients and try to confirm that response or better in earlier lines of therapy. So as you guys are aware, both GY018 and Ruby were presented simultaneously at the SGO annual meeting and published in the New England Journal of Medicine. Similar trials with some salient differences. You can see the schema here for NRG GY018. Prospective, randomized clinical trial looking at the combination of chemotherapy with pembrolizumab or chemotherapy plus placebo with maintenance pembrolizumab or placebo for up to 2 years. Some key points. Prior adjuvant therapy was permitted as long as it was at least 12 months. Carcinosarcoma were not allowed to enroll in clinical trial. There was no central path review, so we relied on sites to tell us what the histology was, of course. And then importantly, again, 2 years of maintenance therapy. And the study was designed to answer the question of the combination versus placebo in both the pMMR and the dMMR populations separately and independently. And that's why you can see it's a large trial. 225 dMMR patients, 588 pMMR patients. 25% of the pMMR had serous histology, nearly 6% clear cell, 25% prior adjuvant therapy, so a pre-treated patient cohort. And this was the data that was shared. On the left-hand side, you can see the median progression-free survival, a median duration of follow-up, 12 months in the dMMR, 8 months in the pMMR, a very significant reduction in the risk of disease progression or death when we add pembrolizumab to chemotherapy in the biomarker select population, hazard ratio of 0.3, 70% reduction. Median PFS not reached at 12 months, 74% of patients without progression. In the pMMR population, again, a provocative, we thought, signal, hazard ratio of 0.54, an improvement in median progression-free survival from 8.7 to 13.1 months. The Ruby trial, in a very similar manner, looked at chemotherapy backbone with carboplatin and paclitaxel with dostarlimab versus a placebo. Carcinosarcomas were allowed to enroll, capped at 10%. Importantly, prior adjuvant therapy, as long as the chemo-free interval was 6 months or greater. These are some of the salient differences. And then also importantly, it was designed to look at the dMMR and then the intent to treat population with exploration in the pMMR cohort. And again, you can see here the robustness of the data. In the dMMR, hazard ratio of 0.28, the control arms are almost an identical median PFS, 7.7 and 7.6 months. So it shows the consistency of the data. In the overall population, hazard ratio of 0.64, highlighting the efficacy. And what we already saw reported, 33% maturity for OS and Ruby, was not yet ready for maturity in 018. But you can see here once again a dramatic signal, even though there is meaningful crossover. This is key. This is key. Even though there's meaningful crossover, in the DMMR population, the hazard ratio is 0.3 for overall survival. And there appears to be a very provocative signal in the PMMR patient population. And I will say that there were 3 studies here listed simultaneously. There was also the ATTEND study, which was atezolizumab internationally. But we also had a press release from DUO-E. DUO-E is a similar trial, but added olaparib as part of the treatment arms, 3-arm trial, to determine whether or not, based on alternate data looking at DNA damage repair, HRD and endometrial cancer, can adding olaparib help even augment the response further. Press release indicating it's a positive trial. We're eager to see the data presented at an upcoming scientific meeting. So I thank you guys for your attention. We'll pause there and have hopefully what's a lively discussion.
Yeah, thank you so much. So Ramiz, I'm going to use first names just because we're all friends. And congratulations on your presentation at SGO. That was a mic drop moment. How many people here were there? It was huge, yes, huge. And I think we all went home and changed our standard of care that very week. One of the things I wanted to ask you is some of your inclusion criteria was pretty tight. So do you extrapolate this data to other patients? For instance, what about patients with stage 3 disease, sentinel lymph node positive endometrial cancer? What are you doing there?
It's a great question. Me personally, I envision those sentinel node positive patients to be patients where, unless you have done radiographic imaging after surgery to exclude other sites of potential nodal disease, I would consider this treatment therapeutic strategy for them, particularly in the DMMR. I know the PMMR, we can debate a little bit.
Wait, isn't that the purpose of B21, Brian, to answer that specific question?
Yeah, no, Brad, that's a great point. And for those of you that don't remember, B21 is a closed trial, 1,200 patients in the adjuvant setting, 1,200 for the high-risk adjuvant setting, looking at chemotherapy plus minus pembrolizumab. So yes, we will, hopefully we'll get the data soon, but yes, that is that strategy. But also, I agree with Ramiz, we have an excellent tool against this disease, particularly the MMR patients, so it's something we can consider.
There you go.
But we have to wait. We have to wait until we get the final data.
All right, so building on that, so we're talking about DMMR. What about patients with PMMR? So Tom, what are you doing for those patients with endometrial cancer?
With PMMR? Mm-hmm. Yeah, the data is challenging, and I think part of it is a little bit hard to reconcile the hazard ratios that you see between the 2 studies. It looks pretty good in 018, not so good in Ruby. What are the reasons behind that? So I'm a little more guarded on the PMMR right now. I know it's NCCN guidelines. I'm going to be very interested in see what the regulatory authorities say about it.
Ramiz, do you think that the follow-up had anything to do with the discrepancy? Because the follow-up in the PMMR was very short, but in Ruby, it was more than 2 years. So
super important question. Median follow-up, 8 months in the PMMR population. The follow-up time
in GY018.
In 018. That can affect your point estimate of the median PFS more substantially. But the morphology of those curves, and we can pull them up, the shape of those curves, to me, means something, speaks to something. We'll see with follow-up. Of course, we're going to get updated PFS data, and we'll see whether or not the median PFS changes. And if so, what does it do to the hazard ratio? Because the hazard ratio goes risk over time, and that is key. That is such an important point to hammer home, so that we don't get fixed at a point estimate which is not applicable to the patient sitting in front of me in clinic tomorrow.
All right, so I'm going to talk about that patient in front of you all in clinic. What is the audience doing? Are you treating patients with chemotherapy and IO if they have PMMR, advanced endometrial cancer? Just raise your hands. Okay, this side of the audience is like, okay, there must be some differences here statistically between the left side of the audience and the right side of the audience. I think
We're
it
the
has
very,
to do
very
with
divided
it's Oklahoma.
Maybe it's
I don't know what's happening over there.
clinical providers versus maybe not, I'm not sure. But anyway, it's a pretty even split. So we'll see. We'll have to do some statistical analysis on there. I'm going to turn this to Brian for a second. And I just want to give a segue into what you're going to talk about, because you're going to be talking about a lot of trials that are coming up. So don't answer right now, but I want to bring it back to this PMMR population and trials and drugs that are on the horizon that may be opportunities for these patients that we need to consider.
Yeah, no, and we will talk about that later in the session. But just one thing to highlight, it's not a slam dunk. We know that from the PMR data that's been discussed. It's not a slam dunk. And we are a group of folks that consider ourselves clinical trialists. All of us. Our GOG network is 350 sites. So in an area that's not a slam dunk, it's always important to learn more. Teaser, we're going to talk about other trials in this setting. Outside of the trials, though, it's a strong consideration to include IO in this population.
And Ram, so I'm just supposed to ignore the median 2-month in 0.76 hazard ratio. 0.76 hazard ratio in Ruby isn't very good. So you can argue with me. You're not arguing.
No.
But with a 2-month median. But even at the hazard ratio of 0.76, my response is, really?
So there's many points that we have to consider. Firstly, not all PMMR is PMMR. It's not just one biomarker. It's a TMB question, it's an MSI question, it's a PMMR question. Secondly, how was the study designed? 588 PMMR patients. That is a lot of, it's almost a third more. So what does that mean for the analysis, the assessment? It was designed to answer the question. So I think we take the data for what it is, a hazard ratio. We wait for the data to mature further, as you mentioned, and then we adjudicate that in the context of emerging data, and we make a decision.
And we're friends, and this is the fun of it. Yeah. So almost all uterine serous cancers are PMMR, right?
Right.
And how many of those are TMB high or MSI?
Less than 5%.
Okay.
Well,
Now
that's what
I will
we
tell.
need to do better.
Oh my goodness!
How many
you
are-
got me all
I'm
wound
going to
up
bring
now.
this back. I'm going to bring us back to clinical, because that's what you all want to know about, right? You don't really care about point estimates and 0.72 hazard ratios versus 0.73, right? So you want to know what you're going to do in clinic. So I'm going to turn this over to Bhavana. Bhavana, what kind of tests do you get on your patients with endometrial cancer?
Yeah, we test all our endometrial cancers with NGS. In addition, we do HER2 IHC and mismatch repair IHC. Every endometrial cancer patient.
Dave, what about you?
Yeah, I mean, that's the question here is 6 weeks ago or whatever it was now, we were doing trastuzumab on all our serous cancers who are HER2 positive. And we're really not bringing that up into the equation. And so, you know, going on a phase 2 trial, non-blinded, no bicker, the curves in PMMR look pretty similar.
Yeah.
And when you're looking at carboplatin plus IO. So we really haven't answered that question. There's an ongoing trial that may answer that question. You could argue it's the wrong control arm. So, you know, I think that is the testing strategy that I test HER2 on all patients, NGS, POLI obviously, now starting ER. So the question then is, what do I do with a HER2 positive PMMR patient? I don't know the answer. I didn't raise my hand. I have been converted by GY18, has ratio 0.5 with regards to giving them chemotherapy, though, IO therapy. But I really think with better HER2 new targeted agents, this is the next avenue that we have to explore.
Bhavana.
I just want to respond to that. So, you know, I treat those patients on clinical trial. I think there's more to learn, you know, in the PMMR subset. And, you know, we have, at our institution, we have Export EC, and I put patients on that trial. And I know others may have CARTOS. So, and if there was a HER2 ADC that was in the upfront, I would put them on that trial.
I think that's a good point, because to push the needle forward, we need to keep doing clinical trials and not just be complacent with what we found out. But I'm gonna, I think we should probably move on to the next section here.
Perfect.
So,
And it's actually
yeah,
a
go
great
for it.
lead in, the biomarker question, into the next portion of the content. And I think we all share the same passion. It doesn't stop, right? The DMMR data is amazing, PMMR data is good, but it certainly doesn't stop progress. And I don't think that should be the take-home message. Now, many of us were at ASCO, some who weren't at ASCO were fortunate enough to hear Dr. Moore's review of the ASCO data, and Destiny Pan-Tumor02 really was a provocative data set that was presented because of the GYN cancer content. Trastuzumab deruxtecan is an antibody-drug conjugate. It is FDA approved and used in alternate solid tumors, of course, breast cancer. It's an humanized anti-HER2, and importantly, it has a linker And the payload is a topo-1 inhibitor. And as Dr. Herzog, Tom said earlier, topo-1 got a lot of grief for being an ineffective drug, but now that it's a payload, it's resurrected itself as an effective treatment strategy. So what they did in this trial was an open-label, multi-center study. You could see the multiple cohorts that were listed here. Patients were allowed to enroll on trial if they had advanced solid tumors that were not amenable to curative intervention. 2 lines or greater, patient population, HER2 expression by IHC local. This is important, local. And then they did central on all of them to adjudicate, but you were allowed to enroll based on local HER2 IHC assessments. You can see about 40 patients enrolled per cohort, investigator-assessed objective response rate is a primary endpoint. I want to focus just on the endometrial here. You're going to hear about the cervix and the ovary. 40 patients, ongoing treatment, 14 of the 40, 35%, median duration of treatment, 9 months at data cutoff. And here we saw very provocative signal, a 57.5% objective response rate. We think about Keynote 775, lenvatinib pembro versus chemotherapy physician's choice, and we were super excited that we went from 15 to 30%. This is 57.5%. And again, we don't have very granular data for each of these individual disease cohorts, but it's still quite provocative in seeing that. And if you look at the very bottom, median duration of response not reached. That, to me, was a very important data point when I looked to contextualize the efficacy signal seen in this patient population. And if we look at the outcome of response by IHC expression, 3+, 84.6%, you guys. I mean, we don't see numbers like that. And I get it, it's a small cohort and it's early. We'll talk about that. IHC 2+, 47%, all comers, 57.5%. And importantly, the safety signals were not concerning. We didn't see something from the trial that suggested that there was a concern in any of these cohorts beyond what we already knew about the ADC and alternate solid tumors. So again, very provocative data. And that was on the heels of a publication in JCO, 7 Japanese sites, all done in Japan, uterine carcinosarcoma, adjudicated by IHC, 0+, 1+, 2+, 3+. If you look at the confirmed objective response rates in the 2+, 3+, 54.5% for pre-treated uterine carcinosarcoma. And if you look at the low expressors, 1+, 70% objective response rate. Again, small patients, I get it, small patients, but a really, I would consider, outstanding signal. And we're incredibly excited to hopefully see opportunities with ADCs move forward. Now we'll pivot to an alternate antibody drug conjugate. Again, sacituzumab was reviewed and discussed. It is an additional antibody drug conjugate targeting TROP2, different than HER2. And the drug, the payload, ironic, again, a topoisomerase inhibitor. So we have an ADC targeting a different receptor, TROP2, payload with a similar mechanism of action, but distinguished from the prior ADC, and importantly, a higher level of expression here. If you look at all endometrial cancers, it could be as high as 96% in some histologies. And we know that TROP2 expression appears to be prognostic for poor outcome. So this was a stage 1 of an open label study. Alejandro Santin presented this at ASCO in 2023 as a poster. And if we look at the objective response rates in this patient population, pre-treated, right, greater than or equal to 3 prior therapy, 47%. You wouldn't expect chemotherapy to work very well, if at all, in this patient population. Objective response rate of 33%. So it shows an efficacy signal. It's interesting that here we have to figure out, well, is there a biomarker or no? Because TROP2 is so ubiquitous. And if so, how do we define that? And then here again, stage 2 is now open and recruiting an all-comer population for that exact reason. But again, really exciting data, and we're eager to see where this will move in the future.
Thank you, Ramez. So again, we're first name basis. Katie, so let's say I want to treat someone with sacituzumab, which is available, in the TROP2 overexpressors. Is that a commercially available biomarker?
No.
Oh. Mm-hmm. So I can't do that, right, Ramez?
You can get the drug.
I know, but it's and it's only, 21 patients.
Yes.
And 33% response rate. But if I can't get the biomarker, then I probably should just table that and try to work with the sponsor to phase 3 trial, Angeles?
Correct.
Well, I think there's some companies now that are giving all of these biomarkers. They'll give you information about NaPi-B2 in addition to FR alpha and TROP. So this becoming more available, but I think we have to be careful in terms of how do we individualize therapy for patients. I think it's a little bit too early to introduce some of these without putting patients on a clinical trial. That's my thought. Maybe I'm a purist, but I would strongly advocate for clinical trials to be conducted. There's one really important thing too, is we don't know what the overlap is, right? Yeah. Is it FR alpha high the same as individuals who have NaPi-B2 high? We just don't know. And so that's going to be another area of interest to explore. So can I just ask Katie one more question? Because so Katie, you're like a international expert on ADCs. Where do you see these fitting in the endometrial cancer armamentarium?
At the beginning. So
the first line.
First line, absolutely. First line and biomarker directed. I think it's just, we needed to see the data from Destiny Pan-Tumor, and we need to see more of it. We didn't see really granular data from that. And there are other ADCs targeting HER2 with different payloads that are also in clinical trials right now that are enrolling very rapidly and look equally as promising, and you'll see data coming out soon on those. So for HER2, I think it's going to be a frontline play, and expect to see that. And then, we're going to learn a lot from breast cancer. Speaking just of TROP2 targeting, sacituzumab is what has been presented. There are several companies developing TROP2 ADCs. They're interested in this space. Breast cancer, you have HER2, and you have sacituzumab approved. They're already working out whether or not they can sequence those medications in certain patients based on the biomarkers. We're going to learn from that, whether or not that makes sense in mechanisms of resistance and apply it to our population. So I foresee frontline use of ADCs, but I also foresee it being a part of the recurrent armamentarium based on biomarkers and understanding why tumors do and don't acquire resistance. So it's the beginning.
So I agree that the TROP2 overexpression is very tough to come by, and I don't know how to do it either, and thank you for that. But Brian, HER2 testing's been here a long time. So how do I order HER2 testing? What method? Is it breast or gastric? And is 3+ really that much better than 2+, which is what the data suggests? Complex question, but contextualize this very exciting data that Ramez, really where you can go to the clinic, assuming you can persuade payers to pay for it.
Yeah, no, it's an excellent question. To your point, it's been around for a while. Originally, we thought about just mimicking what they did in breast cancer as far as positivity, 3+ IHC, 2+ with FISH analysis. But the interesting thing about the Destiny trial, which Ramez discussed, is that it was based on local testing based on gastric staining.
Yeah. When
they did central review afterwards, a lot of those patients actually were 0 and 1+, and they still found activity.
Yeah.
So, a simplistic answer will be, it doesn't matter. If it's positive by one of the tests, we could use it, right? But we need to do better, and we need to do more to figure that out. But it's an exciting avenue to pursue. If you can get the drug, use it.
Yeah.
And then just real quick to Katie's point about moving to the first line, remember, if B21's positive, which we're going to discuss, it doesn't necessarily have to push IO out of the front line, because IO may move to the adjuvant setting.
Right. So Katie, tell us more about HER2 testing in your practice, and really what we can expect for positivity in endometrial cancer.
So we're learning that. So the data that we have to date really is focused on traditional breast screening, as Dr. Stolmovitz just alluded to, 2+-ish or 3+. So it's about 40% of serous. Now that we are picking up the 1s and 2+s, and you have to remember, in the day when it didn't matter to be 1+, the pathologist would just say 0 because it didn't matter. And now they're having to differentiate the 0s from the 1s, and so we're picking up the 1s. So it's probably another 20% of serous are positive, 17% of carcinosarcomas, and an unknown percentage, but probably about 10% of the grade 3 endometrioids.
Yeah.
So really, we're talking about, it's still a minority, but it's a sizable minority that we're going to find HER2 positivity 1+ and up, and that's probably going to be our population who will benefit substantially from these medications. But really nailing down the biomarker is tricky.
Yeah.
Tricky.
So on that note, we have a lot more exciting things to talk about. I think, Ramesh, you're going to talk a little bit more about WEE1 inhibitors. I'm trying to anticipate what's your next slide.
No, so we're going to review a little bit of the upcoming landscape of trials in development, but WEE1 inhibitors are a part of the therapeutic exploration in the endometrial cancer space, but again, more is to be done with even the WEE1s.
There we go.
Now I'll take over from here. As you know, I'm the clinical trial advisor for the GOG partners. Just as an aside, I'm thrilled. If you guys have been to the highlight reels, usually uterine cancer is like at the end. Based on the year we've been having, they moved to the beginning. So Brad, Tom, Angelos, thank you for that opportunity. I want to go through some of the trials that we don't know the answers to yet, that are either ongoing or have completed accrual, and that they'll help us to consider how we're going to change the landscape. And you know, it's an exciting time. It's an exciting time. It continues to be an exciting time. There's several studies that we'll read out in the near future, and we'll touch on those briefly. GOG 3064, this is the Merck Keynote C93 study. It's a study looking at pembrolizumab alone, IO alone, in the DMR setting versus chemotherapy. One passion for me is to try to get rid of chemotherapy for endometrial cancer overall, particularly in the first-line setting. This is a randomized phase 3 trial, DMMR patients, comparing standard of care, carboplatin paclitaxel, versus pembrolizumab. The chemotherapy arm is allowed for crossover, dual primary endpoints of PFS by BICR, and overall survival. Answering an important question. Some criticisms, well, ever since that day in March, Ramez and Mansour sort of messed up your control arm. Now it should be IO in the control arm with NCCN level one data. And then once we get the conclusion here, there's going to be a lot of discussion of how we play with it. One thing I want to say, just announced this week, based on the NCCN recommendations, this trial is now, it's a global study, but it's closed to accrual in the US. That's the public information. We've seen that before in other drugs that have gotten recommended to use in the US, but it's accruing and it'll accrue nicely, and we still anticipate this to be closing sometime in the near future. Here's some pathways we're going to move forward, and as we sort of discussed, remember, what are we going to do in the PMMR setting? And what we discussed is, well, IO is a consideration, but we also highlighted the fact that clinical trials are something that we should strongly consider. One of the things we know, 50% of endometrial cancers are P53 mutated or P53 wild type. And these are a group of patients, not the serous patients, not the carcinosarcomas, but more along the endometrioids that are wild type P53, that are still PMMR. Endometrial cancer is chemotherapy sensitive, 52% response rate, suggesting susceptibility to the P53 mediated tumor cell apoptosis. Endometrial cancers also overexpress MDM2, which is a protein in up to 50% of endometrial cancers. Dysregulation of P14 through the CDKN2A promoter hypermethylation occurs in up to 57% of endometrial cancers. This results in intranuclear MDM protein upregulation. And you can see from the slides on the right some of this overexpression. So MDM2 is a key negative regulator of P53. It modulates P53 activity by directly inhibiting P53 transcriptional activity, transporting P53 out of the nucleus, and ubiquitinating and tagging P53 for proteasomal degradation. MDM2 upregulation or overexpression within cancer cells can drive cancer cell proliferation, and inhibitors of MDM2, and this is what we're going to talk about in our next clinical trial, can restore normal P53 tumor suppression function, leading to cell death. It's a promising target for anti-cancer drug therapy, and it's one avenue that we're pursuing. Here's a study that's been announced. It's in the public domain. It's a registration-directed phase 2 design, 2-part randomized phase 2 to 3 maintenance study. Give chemotherapy maintenance trial in endometrial cancer. One of the things that we're seeing here in the next slides that I'll talk about, in patients with P53 wild type advanced or recurrent endometrial cancer who responded after chemotherapy. 1-to-1 randomization looking at 2 different doses of navtemadine, 180 or 240 versus an observational control. If it overcomes the first evaluation of part 2, looking at 195 patients based on the dose of the drug compared to placebo. Primary endpoints Part 1 is to get the dose. Part 2 is PFS by BICR. We're really excited about this protocol. And here, pMMR patient, P53 wild type, in your practice, if you have this trial open, we like to push for clinical trials. We encourage you to enroll into this trial. Next, now this is a drug that we're sort of familiar with. If you took part in the SIENDO trial, and I'll go through the slide, it's a selinexor, a nuclear transport inhibitor, results in reactivates tumor suppressor proteins such as P53. It inhibits oncoprotein translation and simultaneously targets several oncogenic pathways. And here's a cartoon on the left basically showing how it's a nuclear transport inhibitor. So in the first trial, and this was presented by Ignace Vergote, one of our partners in ENGOT, and secondary study presented by Vicky Macker. This is the primary endpoint of the study, looking at PFS in the ITT population. I don't want to spend much time on this. The lines are very similar. The bottom line is the ITT population didn't hold water when we looked for an FDA approval. Okay, but when we looked at a subgroup analyses of the P53 wild type patients, things changed. Look at the separation of these curves. This is an updated, in the public domain, updated PFS curves in this subpopulation. Median PFS in the selinexor group, 20.8 months. Placebo is 5.2. Now, when we presented this to the FDA saying, hey, this is good, what can we get approval? Not a primary endpoint of the study. You can get approval if you do a study and you confirm that this is your finding. Looking at the data, here's more compelling data. When we looked at the subgroup analysis based on MSI or MSS population, we know the group on the right, MSI, they're going to get checkpoint inhibition. But the group on the left, MSS, the lines still are separated 27.4 versus 4.9 months. And here's the ongoing trial. So we're going to have two trials in the setting, the CARTOS trial and the selinexor trial. This is Export EC042, randomizing patients P53 wild type, respond to chemotherapy, maintenance trial, the selinexor versus placebo. The difference between these two trials is this has very good supporting data that was actually accepted for publication, being the SIENDO trial. So we're going to move forward with this setting, primary endpoint being PFS assessed by the investigator. Other studies that we have ongoing, I want to go through these quickly. What's the role of CDK4/6 inhibition in endometrial cancer? This was a phase 2 study presented by Mansour it's based on the ENGOT group. In these cytostatic agents, we're really looking for PFS, not necessarily response. CDK4/6 inhibitor plus letrozole versus letrozole placebo. Median PFS, 8.3 in the study arm versus 3.0 months. Based on this data, in our group, we're doing a first-line study of CDK4/6 inhibition with letrozole versus letrozole placebo. We're really excited about this because another way of getting rid of chemotherapy in our low-grade tumors is taking advantage of this hormonal pathways, biomarker-driven pathways, to control the disease and help our patients do better without the toxicities. Here's a one-to-one randomization with the primary endpoints of PFS. Other trials that we have that we just wanted to highlight, this is a phase 2 open label trial of the checkpoint inhibitor by the Incyte asset. This is retinfalimab. The first two arms are for registration pathway, not really in the US domain, looking at outside US in a global setting. But arm D is looking at those patients with an FGF mutation in their tumors, combining with a checkpoint inhibitor, interestingly, in patients that were pre-treated. So this is a study that's looking for patients pre-treated with IO, following up with IO. And the last arm, RMF, is adding TIM and LAG inhibition to the checkpoint inhibition if we can overcome that IO resistance, again, an IO after IO study. Really cool study here, alpelisib and fulvestrant in the PIK3CA mutated endometrial receptor ER positive endometrial cancers. We're a group that supports investigator-initiated trials, and Stephanie Gayard is doing a great job in this study that'll be open through our group. And finally, I was mentioning we're going to be, these studies are closed to accrual, but this data may affect what we're going to do. It was, Ramez mentioned earlier, the ATTEND trial, chemo plus minus atezolizumab. I went through GOG 3064, and the LEAP trial is another one that's going to read out soon. In the pMMR setting, getting rid of chemotherapy, chemo versus pembrolizumab. We know the combination works in the second line. We're trying to see if that works in the first line. And then here these are the slides for discussion, but again, and Brad and Angelos will lead this. What are we going to do in a DMR setting? the PMMR setting, and finally, what if B21 is positive? Turn it back over to you guys.
That's just amazing review. Thank you so much. So a lot of exciting news on the horizon and a lot of great drugs, and we're going to figure out how to use them clinically. I'm going to turn this over to Brad because I already saw what he scribbled for his first question, and you're passionate about this, so go for it.
So Brian, first of all, I want to thank you for your leadership in the endometrial space. And great teams take leaders, and I appreciate it. And I know, Ramez, you've contributed that as to the rest of the GOG leadership, and most importantly, to the investigators, so thank you. So let's sort of break it down. Beautiful conversation into the DMMR, the PMMR, the P53, and the hormonally sort of driven tumors. Let's start with DMMR. So, and again, congratulations, Ramez, to GY018 and Ruby. C93, as you said, is a checkpoint versus chemotherapy in the DMMR subset, which, just like in colorectal cancer, will be positive. Now, Dave O'Malley, you've had a very nice JCO publication about, pembrolizumab in the DMMR positive subset. If C93 shows that it's better than chemotherapy, how does that inform the superiority to the triplet combination in Ruby GY018, which was already, as I think you guys agreed, the standard of care? So is C93 relevant today? In other words, is the control arm irrelevant?
Well, I actually think the crossover here becomes an extremely important question because it really becomes a sequence question versus a combination question or replacement. So if C93 is positive, we are going to have to see what crossing over, because remember in 158, we had response rate right at 50% at the most recent presentation, 50% of our DMMR patients. Of those, about 2/3 will have long-term disease control, maybe cured. So the sequencing question is going to continue to persist. I believe we need to use the best therapies first to increase that chance of curative intent. So unless the sequencing question really is definitive that you can use them in follow-up, but the same thing could apply if the single agent's positive, maybe you could omit chemotherapy.
Well, I just want to throw this out to the audience. So, again, different control arms, right, between these two studies. If C93 is positive, how many of you feel comfortable dropping chemotherapy and treating with the IO agent only in the advanced frontline setting?
Depends on
Josh is like, you're there. Okay, really positive.
Bhavna, what would it take to convince you to drop chemotherapy from the Ruby GY018 triplet?
I think if I'm seeing an impressive hazard ratio, and I also think that we're going to have to look at this subset more carefully. Yeah. Perhaps it's the somatic and the Lynch-like that you may see these amazing responses in, as opposed to the hypermethylated ones. So
tell us why that might be important.
Yeah, well, it's important because we've seen varying data in the literature where we have seen 100% response rates, close to 100% response rates in the Lynch-like or the somatic mutated ones versus much lower, like 33% in the methylated. Mm-hmm. And the pembrolizumab data is very different than the Garnet data with dostarlimab. So I think really looking at these subsets in C93 is going to help me as I make this decision.
Tom Herzog, any comments on that?
No, I mean, I think that, as we carve up these molecular subgroups,
carve it up. I love that.
Start looking at all the different permutations, we'll finally get to where we need to be. I just think that likely you'll probably lose some patients there, to Dave's point, of not putting your best therapies all forward. The question is, I think, patient-reported outcomes, toxicity, all that will figure in as well, and you're going to have to balance those things out. So it's going to be interesting to get all the data and compare it.
Go ahead, Brian.
Yeah, one of the things that we've looked at recently that's very interesting, when you look at the curves of GY018 and Ruby, during the first 6 months, 4 to 6 months, when they're getting chemotherapy, they overlay each other. There's really no difference. So the question there is, does the chemotherapy make a difference? Does it? And to Bhavna's point, we're going to have to come up with hazard ratios. There's 3 options. The hazard ratios are going to be similar to the 0.28 and 0.3, which is phenomenal, right? Those are better than or comparable to Solo 1. they're going to be worse. Then you have to figure out in your mind how worse will you tolerate to give to your patients. 0.35, 0.40, we'll have to see. But what's the third option that we're not even talking about? What if they're better? What if it's lower than 0.28, which will be tough to do, but who knows what chemotherapy is doing in this setting?
Well, I know what it's doing because in Ruby, let's say, the response rate of chemotherapy alone is about 60%. That's what it's doing. And it's going to be hard for me to say, oh, I don't need that. The added response rate with checkpoint, even in the DMMR subset, is less than 20%. So it's going to be very difficult for me to say, you know, that's 60%, I don't really need it. What was single agent checkpoint, 50%? Yes.
In the second
in the
line.
recurrent setting.
Second line.
To Brian's point, when we look at the GI data,
Yeah.
this response rate without prior therapy may
I
be
hear you.
markedly higher.
But I
And
will
maybe
add-
we're curing even more patients with sparing them chemotherapy.
Well, I think one thing that's important here too, might not be a 1 + 1 = 2 situation. It might be actually that chemotherapy could be harmful to the immune system. So I think we have to wait until we get all these results.
I was going to
So-
say, Brian, to your comment about the hazard ratios, would anyone feel comfortable if the hazard ratio is slightly worse to abandon in a patient that's eligible for chemo? So say it's not 0.3, like you said, say it's 0.45.
Not me.
Not me. I would continue to use the combination if a
it's just-
patient
I think
tolerates
the
it.
patient
That's my
would
It might come
want-
off quickly,
Comparing
right,
the
if they're
hazard
having
ratios, though,
toxicity.
isn't going to be helpful.
Yeah.
I mean, because it's not the right control arm. I'm sorry.
That's
So
exactly the point.
It's not the right control arm. So the only comparison for me is going to be cure. How many people did you cure on Ruby?
Yeah.
What's your percentage? We have 2 years in MMRD, it's sitting at 70%
That's
without
right.
response.
It's the tail.
So when you get to 3 and 4 years, if you're sitting at 60%, that's what I'm going to be looking at in the C93 study.
Yeah.
I want to see how many are cured. And to Dr. Pothuri's point, if there's a difference in distribution of your Lynch-like and somatic versus your hypermethylated, those may look different falsely. So the cross-trial comparison is going to be
It's the cure
dangerous
fraction.
here, I think.
It's the cure fraction.
But it's definitely cure.
Yeah.
Otherwise, you can't compare them.
Dave, I
Tom,
think-
let's-
I think Dave wanted to say
Oh,
something.
go ahead, Sid.
You know what, I was just going to say, we looked at this, the dostarlimab, and we look at the Lynch-like syndrome versus MMR deficient. They didn't really look, Garnett study with dostarlimab. They didn't really look different, so.
But that was with the surrogate.
But that was a
Correct.
yeah, thank you,
Wasn't
Katie.
really looking at it.
But such a small population of patients, that subpopulation of Lynch-like is going to be extremely difficult to really tease out. Now, maybe they're all cured 100%.
They may
It
be
won't be
cured.
difficult.
Yeah.
So let's pivot now to PMMR because there's some analogy there. We have the same treatment in PMMR, already FDA approved, pembrolizumab and dostarlimab, and we're also studying it in the front line versus chemotherapy in LEAP-001, just like we're doing in C93. So Tom, again, how do we, and I get it, it's fun to talk about this now, so when we see the results, we can already begin to contextualize it. Is the control arm in C93 also wrong? Because Rama said we should be getting triplet therapy in the PMMR subset. Or is chemotherapy an acceptable control arm in LEAP-001?
Well, I think globally, it's an acceptable
Yeah.
control arm. I think in the US, it's challenged, and they've reacted to that challenge.
Do you think that, because that's 2 years of treatment, right? And I get it, it's 2 years of treatment also if you get GY018 or Ruby. Alopecia maybe, is there some leverage with alopecia bovna in LEAP-001? Because the pembrolizumab, obviously, there's not.
I mean, I think the other toxicities outweigh the alopecia and the need to stay on for 2 years, so.
Well, neuropathy too.
Right.
That's something that needs to be considered.
Katie, do cold caps, right? Do you use cold caps in Oklahoma?
We try. We use cold caps, although now with oxaliplatin, we're not using cold caps, but in general, we do. But I will tell you.
Tell why that's true, because I don't think people understand that.
Oh, so with oxaliplatin, you get these cold-induced neuropathies. So you have to stop, if you're switching your patient from carbo to oxaliplatin and you have them on the cold mitts and the cold socks, which we do all the time, you have to stop that or you're gonna make their neuropathy terrible. Just a little tidbit on the chemo shortage. But we do try to use cold caps a lot. It's part of our counseling, but it's not covered by insurance. And as all of my partners are sitting here can attest to, we don't take care of a wealthy population and a $300 rental rate is often not, it's a non-starter per each month for our patients. So I don't feel like we get them very often for our patients. We try, but they don't use them. And also, I think the other thing about cold caps that people don't recognize unless you put one on your head, they're very uncomfortable and they're very heavy, and patients don't like them at all. So we try, but I think it's not as easy as maybe it is presented.
My last clear cell patient, which she's not a clear cell patient, she's a patient with a clear cell cancer, brought in this cooler and just used wet ice. And it worked pretty well. In fact, she didn't put it over her sideburns, so her sideburns fell out, but the hair on her head was preserved. Water everywhere, because it melts, right? So when she said,
Can we get back on subject, please?
all right,
I thought we weren't going to go down rabbit hole.
all right.
No more patient anecdotes.
All right, down boy.
Fred, 2 quick comments.
Thank you.
First one's half jokingly, you can't talk about alopecia. 3 of us on stage suffer from it.
There you go.
We're a little bit biased. But
That's
more
why O'Malley was sensitive. Go ahead.
But more importantly, when you look at LEAP 001, the other question that we haven't discussed yet, it includes DMMR patients. Another cross-trial comparison is going to be, do you need lenvatinib in the DMMR patients when you're comparing the results of C93 and LEAP? And we don't know the answer there.
Thank you for that. So I loved your presentation about P53 as a target. Really P53 wild type in these 2 GOG-sponsored trials. I would hope that all of you would open either I'm going to say it, Brian, NAV to Madeline versus the selinexor, both maintenance trials in patients that respond to frontline chemotherapy and then ultimately are P53 wild type. So the tough question, and it's tough, so I don't know who to answer it because I don't want to put anybody on the spot. Well, I'll just put Ram. Ram is my fellow. We always sort of challenge the fellows. So in the PMMR subset, what percentage, and PMMR is about 75%, where checkpoint has marginal benefit, what percentage of PMMR patients are P53 wild type?
It's a great question. I would guesstimate, based on the data that we have, based on the population of patients and the histologies accrued to Ruby and 018, it's about 40% of
What do you say, Brian?
PMMR.
PMMR.
I was at 30 to 40%.
Of the 75%.
Of the 75% that were enrolled, because you're excluding the DMMR, which is a 25% that you're referring to.
So I say it's about 30% of all comers, which is about 40% of 75%. There you go. So
I'll
that's
be able to tell you that. So shameless plug for our abstract for GOG 258 being presented at IGCS.
Yay.
So if you go to Korea, you'll get this information right there in the audience. But yeah, I'll let you know.
or go to the highlight reel in the fall.
That's true too. So we'll see. So you got a 30, 40, 30.
So 40% of PMMR, which is 30% of all comers, is my final answer.
Yeah.
All right, let's see.
Okay. If you had neither trial open, Brian, if you had neither the NAV to Madeline, I have to write it down, NAV to Madeline or the selinexor trial, how do you pick which trial to open, or maybe you just need to have one of them open?
Right, so it's actually 3 company-sponsored trials, the 2 that you mentioned, and the CDK4/6.
I'm going to get to that, but right.
Right, but just so which ones?
Yeah.
It's an interesting point I want to highlight. So you should have one of the 2 open from a site management organization. We're making sure as best as possible that your site won't have both open. We have enough sites not to let that overlap happen. But I like both of them.
Yeah.
Interesting. I think the CARTOS is a very interesting pathway to try to explore. And then on the flip side, Export has some supporting data in the phase 3 setting to look in this disease. And I know you're going to go into CDK4/6, but before you dive into a little bit, now if you remember from Ruby GY018, it allowed for prior hormonal therapy. So you could actually open laracyclib letrozole versus letrozole placebo.
Yes.
And once you complete, hopefully the patients will be cured. But if not, and you're giving first-line chemotherapy, then they could go on one of those 2 trials.
I love it. I love it. I love it. Okay. And to be clear, for those of you that participated in SIENDO, which was the proof of concept for Export EC, the dose in Export EC is a little lower than Siendo. So I don't want to say, well, I enrolled a Siendo, I didn't really like the tolerability, so they've dialed it down a little bit. And so that's an important thing. So let's talk about hormones. Tom, who would be the patient where you could withhold chemotherapy for now and put on a hormonally questioning study, this EQRX study, which is letrozole versus letrozole CDK4/6. I get it that they have to be grade 1 or grade 2, but what does that patient sort of look and feel like?
Well, in general, I obviously express the target, so ER.
Which is not necessary for the trial, but it's
No.
okay, you can choose
But they're
that
using it as a
patient.
surrogate.
That's right, I like it.
Right. So those would be the key things. I think a lot of us actually check. Dave, you do, I know.
Yeah, that's-
And a lot of people do. Katie, do you check hormone status?
It's, it kind of comes as a standard
Yeah.
panel, but I would if it weren't there, yeah.
If I'm putting them on, I probably want to know that.
I think the clinical kind of features, do you think, like for the lerociclib, letrozole versus letrozole, are you sort of selecting patients who aren't particularly symptomatic from their disease, like like the patient that has an incidental lung metastases, or, you know, not like ascites and incredible abdominal disease, or do you feel like it's all?
No, I think that the symptom index is very important. If it's something you need an immediate response for, that's something you're probably not going to pursue at that point. You're going to probably go with more aggressive therapy. But, you know, I've seen some amazing, but it takes a little bit longer, but I've seen some amazing responses.
We
to
all have,
therapy.
right?
We all have.
And the term that I like to use is that patients that are at low risk for visceral crisis, that symptom is one way to do that. But even if they're asymptomatic and I look that, you know, maybe they're at risk of a kidney or a biliary, you know, obstruction or some sort of airway post-obstructive pneumonia, and then I would sort of look at it in that way. And that trial's open, Brian, is that right?
EQ, the lerociclib study is open, yeah.
And are sites still available for that? Are they, where were they at in site selection?
We're at site selection. You know, what I always encourage people to do is reach out to me if your site's interested. Not saying that we have a waiting list, but there are situations where sites fall off or situations where companies want to get more sites. So we never want to shut people out, so shoot me an email and we could, if nothing's open, put you on top of the list. Or, more importantly, know that you're interested for the next study that comes along,
Right.
because we like sites that are interested.
And I think what's important is to try to join trials early, and this trial is just getting going. And so even though, you know, these patients are not necessarily real common, there are enough of them at your site because endometrial cancer is the most common cancer that we treat. Are there any ethnic Bhavna relationships to the low-grade tumors, these hormonally driven tumors? In other words, are they less or more common in underrepresented minorities?
They're actually less common. Black patients have a higher incidence of the P53 mutated and the HER2 overexpressors. So I think we just need to keep that in mind.
Good point. All right, other comments about our endometrial portfolio before? Yeah.
I just have one comment that we didn't mention, because I think we all are particularly passionate about HER2 and the testing. But the study that is in the front line that's ongoing right now is NRG-GY026, led by Dr. Britt Erickson. That is paclitaxel carboplatin with or without trastuzumab, which we might say is a quarter century old and an older drug, but it is open. It certainly is still relevant in breast, and so is an important question. And also importantly allows early stage HER2 positive by traditional testing 2+-ish or 3 serous tumors, where data would suggest those patients' tumors have a particularly poor prognosis, and so you might want to use chemo and a maintenance agent. So I would encourage us, I know there's a carbo shortage, which has put all of these on hold, but please keep that study in mind. It is an important trial that took many, many years to open, and it was just missed. So I wanted to make sure we celebrated Dr. Erickson's trial.
I wonder if that's going to become an early stage trial.
I think it might be an early stage trial.
Yeah.
Especially as the ADCs move into frontline, which we expect them to, but that's not going to be for a while, and I think it is an important question. We need to support it if you have carboplatin, which is
So I'm gonna.
the issue.
So Katie, I think that's a great point, and thank
Let me
you for
just
bringing
make
it
one
up.
comment. One of the innovative components of that is the hyaluronidase formulation that's sub-Q. which I think is an important question.
Yep.
So go ahead, Angela.
Oh, no, that's okay. I was going to say, that is a perfect segue because we're almost out of time for endometrial cancer. So thank you so much.
Thank you.
That was really fantastic,
Right.
Brian and Ramos.